Hey everybody, welcome back to the ECG channel. My name is Reed, and before we start today's ECG, go into the description below and download this PDF so that you can follow along and make your own notes, save it for later. Feel free to like and subscribe while you're down there and support the channel because we love making these videos. So let's go ahead and get started on this one. So first thing I'm going to do is look at the force and trees of the force from our QRS complex. And so I'll start maybe at lead 2 here, and we'll notice that we've got a wide complex rhythm. If you look really closely, that rhythm seems to be greater than 120 milliseconds, which is 3 little boxes. So we've got a wide complex rhythm. So we'll start off by go ahead and making some notes. Wide complex rhythm, and if we kind of follow it throughout, it seems to be regular until we've got this pause here. So we've got this pause, and then it resumes, and we have this nice regular rhythm throughout the rest of the strip. So we'll work through that pause. Now that we've kind of seen it, it seems like we've got, if you look, there's P waves before every QRS. So we've got some atrial activity. We've got a wide complex rhythm. So first thing that comes to my mind is if it's a wide rhythm, then there's likely some type of conduction delay within the ventricles, right? Because the QRS width has to do with the kind of the His-Purkinje system and its function. So our rate here, if I find a QRS that is on a solid line, say like this one, I can count my rate: 300, 150, 100, 75, 60, maybe 63 or so beats per minute. So, alrighty, let's start going through our algorithm. So first thing I like to do is evaluate what my atria is doing, and I look at the P wave. And so my P wave, if you look here in lead 1, is upright. And if you look in lead AVF, it is upright. It tells me it's going down to the left, which is normal. And so this is a sinus P wave. And next thing I'm going to do is I'm going to evaluate my PR interval, which my PR interval correlates to my AV node. Right? So I'm just kind of marching down the our highway conducting system. And so if I measure the AV node, maybe I'll pick lead 3 here. I find this QRS, and I find the beginning of my P wave, and I'd say it's borderline. Looks right around the PR interval, looks right at 200 milliseconds or so. So I'd say it's borderline, but we're not going to call it a first degree AV block for now. If you look really closely, sure, you might be able to find it, maybe 210. That's okay. So if we got a PR interval that is kind of not glaringly bad, and so the next thing we're going to do is make sure that those P's and PR intervals stay the same the entire time. And so I notice here that I've got a P, QRS, P, QRS, P, QRS, and if you march through, it seems that these P waves and the PR interval is the same. I'm trying to figure out maybe what's going on there, but I think we can save that for at the end. Next thing I'm going to do is evaluate the QRS. We say we have a wide complex QRS, and so let's measure that. If we look down at our marking here, it looks maybe like 4 little boxes, and so that means our QRS is, if each block is 40 milliseconds, it is roughly 160 milliseconds in duration, so that's wide. What is our differential for wide complex QRSs? We've got maybe left bundle branch block, right bundle branch block, bivesicular blocks. You could have hypertrophy with secondary widening of the QRS. You could have a ventricular ectopic beat. I don't think it's a ventricular ectopic beat. Why? Because we see that we've got these sinus P waves that seem to be conducting to the QRS, and our QRSs are occurring at a regular rate. So it makes me think that the atria is driving this. Let's take a look at our QRS axis. We've got a QRS that is upright in lead 1. We've got a QRS that is down in AVF. So if it's going towards lead 1 but away from AVF, that means it is likely going somewhere up and to the left. And if you look here, it's negative in lead 2. My QRS is negative in lead 2. And so if I look at lead 2, which is right here, that means that it's going away from lead 2. So that means that we have a QRS axis that is somewhere high up and to the left. And so we know that anything that's past the axis of AVL is going to be kind of in this quadrant here is going to be left axis deviation. Right, so we've got a wide complex rhythm with left axis deviation. What could cause that? Well, we know maybe left ventricular hypertrophy would be kind of a rare cause. I don't see any evidence of left ventricular hypertrophy. And so let's look for conduction disturbance, conduction blocks. And so what you'll notice, the first thing I notice actually, what's interesting and doesn't line up with left axis deviation, is in V1 and V2, I've got this R prime, right? I've kind of got these late signals in the ventricle. That's a late R prime. I'd call this an R prime. So we've got these R primes in V1, and we know that V1, R primes in V1 are actually most consistent with a right bundle branch block, right? If I look at my transverse plane here, which is where we hit our precordium, you can see that the right ventricle, which is here, is my RV. Whenever my right bundle branch is blocked, if this is blocked, signal will initially go to the left ventricle normally and depolarize the left ventricle, and then late forces will make their way over to the right ventricle and depolarize the right ventricle, which is giving positive forces late in those leads that are capturing the right ventricle. So, that's really interesting that we see that we've got a right bundle branch block. So we've got our right bundle branch block, which explains why the QRS is wide, but it doesn't explain my left axis deviation. So right bundle branch blocks with left axis deviation, that makes me think, is there a fascicular block in the left ventricle? And if you look really closely here, we've also got a little q, big R pattern in lead 1, and we've got a little r, big S pattern in lead 3. And so that pattern right there in the setting of left axis deviation is criteria for something called left anterior fascicular block. And if you don't understand left anterior fascicular blocks really well, I've got a video on that too. You can go check it out. So we've got a left anterior fascicular block and a right bundle branch block. So you can call this a bifascicular block. And so the left anterior fascicle kind of supplies the anterior lateral, a little bit of the superior portion of the left ventricle. It's a branch off of the left bundle. And so we've got multiple conduction blocks in this ECG. So we've got right bundle branch block, left anterior fascicular block. All right, so that explains some things there. Let's take a look at our QT interval here. So I'm going to go midway between these two QRSs, and if I draw a line right down the middle, it seems like my T wave ends before then, so I'm happy with my QT. So good with that. Let's look for some pathological Q waves and ST and T wave changes throughout. I don't see anything that's really staring, jumping out at me. Maybe septal cues. Like I said, nothing here is really standing out. There's a good chance that this person's got some disease. They've got a pretty significant conduction block, so maybe a prior septal MI, but nothing that I'm gonna really perseverate about. And for ST and T wave changes, I don't see anything that's really glaring in the sense of elevation or depression that makes me think of any ischemia going on. So the last thing we need to do is we need to evaluate this pause. We said we had a pause. So what is our differential pauses? We could have a sinus node that is just stopped. We could have a sinus node that beat early and didn't conduct. And so what I want to look for is I'm going to see I've got this P wave that conducts to QRS, P wave that conducts to QRS, and then I look for another P wave. It should be, if my P wave occurred here, my next P wave occurred here, it should occur right around here, but there's no P wave. I don't see any P wave. I see it's just flat. And so what I'm going to do is I'm going to say, well, did something happen too early that maybe didn't conduct? And so what I see is I see this little itty bitty notch on that T wave. It is very subtle, that little notch on the T wave. And if you compare that to the previous T waves, in the previous T waves, they don't happen. The T waves are usually really slopey and gradual. P waves are usually very sharp. Atrial depolarization is very sharp. And if you look through other leads in the same distribution, you can see this sharp deflection on that one that is not on this one. And so what is that? That is a premature atrial contraction. Because it happened early, we expected our next beat to be on time right here, but that one came early, so it's a premature atrial contraction. And if you look at what happened to that PAC, it tried to conduct, but it didn't. So that's a PAC that was blocked. So that is a blocked PAC. And so blocked PACs occur when the AV node just hasn't been able to recover yet from the previous beat. And so that PAC depolarizes the atria and is unable to activate the AV node, and so that beat doesn't create a QRS. How do I know it's ectopic? Well, it doesn't look like my normal P wave. My normal P waves here are upright. This one is like a little downward chunk, so it's coming from somewhere ectopic within the atria. So we've got a blocked PAC. Alrighty, so let's put this all together. We've got a sinus rhythm with a right bundle branch block, a left anterior fascicular block, and so we would call that a bifascicular block, and we have a single blocked PAC. And so a couple of things I want you to recognize in this video today is when you have a pause like this, to go ahead and develop a differential diagnosis, right? So pause differentials, just a few things that come to my mind. We could have AV block, we could have a sinus node pause, we could have a sinus node exit block, right? We could have premature atrial contraction or premature ventricular contraction, which causes a type of compensatory pause, and there's more, right? What I want to get at is that think through these things so that you can have a framework of approaching the pause. You can look for, is there premature atrial activity? Is there evidence of AV nodal function within the ECG? And so what should my suspicion level be for that here? So hope this helps. If you have any questions, throw them down in the comments, and if not, have a great rest of your day. We'll see you tomorrow.